Welcome to MedEd's production of the CCRN review examination. This is the 5th edition, which includes all of the changes from AACN's blueprint from October 15th, 2015. So it's included everything that's new for the new exam. My name is Cammy Fancher, and I'm so happy that you're joining us to review for this very difficult exam. If you have not gone over the introduction, that might be really good to do that first and then go through the segments as they are so you can practice and study each one. We're going to do gastrointestinal now. I love GI. Do I want to work in the GI lab? Well, not really. The way we sort of look at patients with GI complications, a lot of patients come in with a GI bleed, with pancreatitis, with gallbladder, gangrenous gallbladder. So they do come in with the primary diagnosis of a gastrointestinal problem. But many of our patients in the ICU and critically ill, acutely ill population develop GI problems. Remember, every time we use a vasopressor, every time somebody gets hypotensive, the blood supply to the gut really decreases, and that's when we start seeing problems with translocation of bacteria, infections, malabsorption problems, and all the bad things we see, including GI bleeding. So I don't know if you knew this, and I didn't when I first started studying for this, but 85% of all GI bleeders are upper GI. In my practice with cardiovascular surgery, most of the GI bleeders are lower GI, but overall, 85% of all gastrointestinal bleeding comes from the upper GI tract. So if somebody were vomiting a coffee ground material, you would know that the bleeding is in the stomach or the duodenum. If they were vomiting pretty gross looking blood, pretty red looking blood, you know it's probably coming from the esophagus. If they're pooping black tarry stools, you know it's from the higher up bowel or the small intestines. And what does it look like when they have a really colonic bleed, and especially a lower colonic bleed? It looks like Cherry's Jubilee. Clotty, maroon, hits the sheets, turns red, and has a very distinctive odor. You walk off the elevator and you say, I'm not taking that patient, right? Because you know that there's a GI bleeder there, right? What's bright red blood per rectum, right? That's a hemorrhoid that's bleeding. Do you think anybody can bleed to death, can exsanguinate from a hemorrhoid? Absolutely, especially if they have portal hypertension and that hemorrhoid is under great pressure. It is venous blood. It will take a while, but they can become very hypotensive and exsanguinate. Alrighty. What we do in the ICU now is try to prevent GI bleeding because it is a consequence of stress and critical illness. The use of PPIs, proton pump inhibitors, and H2 blockers has been around for a very long time. As a matter of fact, it is the standard for every patient admitted to the ICU to be started on one of those drugs. We are finding, however, that not everybody needs these. If they did not have GERD or GI problems before and they were not on these drugs before they came into the hospital, we should be keeping them on it during acute illness. But as they get better and start to eat, either regular PO eating or enteral feeding with a tube, they may not need it. And as long as they have normal blood pressure or at least a little bit normotensive, we probably should turn them off. What happens is the stomach should be acid for a reason. There's no bacteria in your stomach. Even there's very, very little bacteria in your duodenum and your very short upper small bowel. All the bacteria is in the lower colon, the E. coli and all of that. Once you change the stomach pH, now those bacteria that are supposed to be in the colon migrate north. And you could have a patient with E. coli in their stomach, and then when they aspirate, number one, it's alkaline, not acid, causes a horrible pneumonitis, and number two, that may be one way that they get E. coli pneumonia. You should not have E. coli in your stomach. So prolonged use, we're thinking about that. We're not thinking that we need to stop it earlier. Unless the patient has been on those medicines at home and they're doing well, then we need to keep them going. So let's just talk about upper GI bleed. The most common upper GI bleeds are peptic ulcers, varices, which we're going to talk about, gastritis, and a Mallory-Weiss tear. A Mallory-Weiss tear is a longitudinal tear of the internal muscle. not a through and through tear. The esophagus has two sets of muscles, right? Two layers. So it's a tear that somebody could get, a normal person, if they swallowed a fish bone, a steak bone, and they actually tore their esophagus. It could happen during an EGD, but the most common cause of a Mallory-Weiss tear is repetitive vomiting. Someone who is got horrible vomiting, like a head injury, projectile vomiting, just starting on anti-neoplastics, or someone who makes themselves vomit, like a bulimic. So they get a tear, and what are we going to do? Well, number one, we want to stop the vomiting as best we can, stop the vomiting. Number two, that esophagus, that tear will heal itself by primary intention. It'll just heal, but the patient has to stay NPO until that's healed. In a normal nourished, in a normal immune patient, that doesn't take very long. But if the patient has had radiation, chest radiation, if they've had multiple procedures, pardon me, if they're immunosuppressed, that's when we get into problems, and then they could have a perforation, righty? Let's go back to just the primary tear. So maybe 3 or 4 days for a normal person, but someone who's very immunosuppressed, somebody who's a bulimic, that their ideal body weight is 50 kilos and they really weigh 22 kilos, it may take them a very long time to heal. So we always have to think about nutrition for them. If you can't, enterally femur, you can't put a tube in, do they need an early G tube, or are they going to get TPN? You know, we don't like TPN that much anymore. Too many problems. Right? If it's a through and through tear, an esophageal perforation, that's a whole different ballgame. Now, stomach contents have come out of the esophagus and are right in the mediastinum. Remember that the esophagus is right in the mediastinum, and now you have peas, carrots, and lettuce in the mediastinum. So it's an open sternotomy, usually, or maybe a thoracotomy, but usually an open sternotomy. They have to wash all that out and then do an esophageal resection, right? So when they come out of the operating room, some of them will be trached, right, if we think this is going to be a very prolonged problem. Some of them will come out with a G tube, because you don't know how long this is going to take to heal, and you're not putting any tubes down there. And they come out with 2 chest tubes, or at least 1, but usually 2. They are not allowed to have anything to eat until they've had a swallow esophagram, and you leave the chest tubes, even if they're not draining, you have to wait until after the esophagram. Okay, so Mallory-Weiss tear, not too bad, get okay, NPO and feeding. A type of feeding, and then a perforation, much more serious. Lower GI hemorrhage, diverticular disease, tumors, and ulcerative colitis. Now, how do you manage anything? This is a patient who is actively bleeding. How are you going to manage this? You always have to think about the ABCs. If they're vomiting a lot of blood, their airway may be in jeopardy, and this would be a very rapid sequence intubation and maybe a very difficult intubation. Soon as you sedate and relax that patient and they lay down, that blood's still coming, they have a huge chance of aspiration. So always the ABCs. Remember, this patient is bleeding, so we have to resuscitate them, and the first couple of things you're going to resuscitate with are normal saline or LR. So you're going to do the vomit, you're going to put big boy IVs in, because you're going to do rapid resuscitation. And they need a Foley. Why do they need a Foley, Cammy? We're not supposed to put Foleys in. I know, but this patient is bleeding. They're hemorrhaging. They may be in hypovolemic shock. One of the outcomes, one of the things that we're going to measure, and one of our vital signs is urine output. So as I'm putting fluid in, I want to know exactly how much is coming out. Crystalloids, colloids, we can't just give crystalloids. And remember, people, when they're bleeding out, they bleed out whole blood. So we're going to start with packed cells. But after 4 packed cells, after giving 4 units of RBCs, you have to think about you have to think about plasma, you have to think about FFP and platelets. Now remember, at this time, when that doctor says send coags, what are you going to say? What do you want? You want a PT-PTT, you want a fibrinogen, you want platelets, you want an H&H. So we need to make sure that we communicate clearly. If their fibrinogen is low, they also have a clotting defect, we can give them all the FFP and platelets and blood, but they're going to need cryo. So we have to be careful about that. Blood transfusions. Somebody is going to say the patient needs an NG tube with an upper GI bleed, and you're probably going to hesitate and say, I don't know where they're bleeding from, I don't want to put a tube in, and GI is coming anyway. after they scope the patient, they can either put the tube in with visualization or they can put it in while the tube is still there. Alrighty? You may have to lavage. You're going to certainly start IV medications. They can't have anything PO. Anybody bleeding upper GI or lower GI, no food, no pills. So everything on your MAR is going to have to go to IV, and sometimes things don't match 1-to-1. So if they're on 0.25 of Synthroid a day, it's not the same as IV. So we have pharmacists help us make all those transitions. In the actively bleeding patient, we're going to start the PPI usually as a drip, a Nexium drip at 8 milligrams an hour. Alrighty? The other thing that we need to think about is this patient is bleeding daily now for the next few days. They need LFTs because their liver may take a hit during this, and they need an amylase and lipase. They already have abdominal pain, so that might be a problem. It might be disguising their pancreatitis, and many people get pancreatitis, acute pancreatitis, secondary to their GI bleed. Even if they've never had a drink of alcohol in their whole life, they may still get that. So we have to monitor that because our physical exam may not reveal that these patients have belly pain. If they have H. pylori, we'll give them antibiotic, we'll fix it. The one thing to remember, especially for the exam, for this exam, is electrolytes and electrolyte replacement. If you have an NG tube in and sucking out all the gut juice, if they're vomiting, if they have diarrhea, they're losing fluid and electrolytes. A lot of doctors with NG tube output do CC for CC replacement. Some do 2-for-1 replacement. So we have to give fluid back. On the test, when they say what causes metabolic alkalosis, not respiratory alkalosis. Respiratory alkalosis is caused by hyperventilation. What causes metabolic alkalosis? And what we learn in nursing school may still be true: vomiting, diarrhea, or excessive NG tube output. So if the NG, nasogastric tube, is in the right place, it's in the stomach, you should see a part of that tube out. You should always see one black line, unless a guy is 7 foot tall. You know, it's a longer torso. But you should see a black line out of that nose. If you come by and that NG tube is only sticking out this much, you know that one of two things. It's either curled in the stomach and that sucking port is laying right against the gastric mucosa, sucking a nice big hickey on there, causing more bleeding. Or if it's got lime green stuff coming out, not coffee ground, not stomach contents, but lime green, you know it's in the duodenum. And now, from the mouth to the stomach, you're probably going to get about 1 liter a day of gut juice. But down in the duodenum, you could start sucking out all the gut juice, which is about 3 liters per day. That's a lot of juice. It's a lot of stuff coming out. So that's 3 liters plus all their electrolytes. You must replace those electrolytes. Please don't forget, at the back of your handout, there is an electrolyte lecture. Please, please, please read that the night before you take the exam. All right, nutrition concerns. Our goal in critical care is to feed people, but sometimes it's impossible. They're bleeding, they're NPO, and they may be NPO for several days. They may not get a DOPOF or a feeding tube, so you may have to remind the physicians, you know, this patient is not eating. Sometimes at day 4 and 5, we can start thinking about peripheral HAL, but in most hospitals today, now you have to wait 7 days. The policy is you have to wait 7 days before you start TPN. And the reason is TPN causes so many problems. More infection, more glucose intolerance and glucose problems, and that leads to more problems as well. So we have to think about feeding, and you're the only person, the nurse at the bedside, that's going to remember it's been 5 days and the patient hasn't had any food. Complications, well, the complications are crazy. Whether it's upper or lower, they still can aspirate. Recurrent bleeds, it bled, GI came, sclerosed it, and then started bleeding from another place. You know, coughing, vomiting, they started bleeding from another place. Acute pancreatitis, so that's why we're doing the amylase and lipase. But during this time when they're hypotensive and hypovolemic, they could have an infarction, a myocardial infarction. They can have DIC because of all the blood products. They have sepsis, shock. They can spiral down, and it happens quickly. Remember too that we probably, even if the liver is normal, look at ammonia levels with those daily labs, because with blood products, people start hemolyzing. They break down that red blood cell and they start getting jaundice. Their bilirubin's going to go up and their liver enzymes may go up. And since the liver is being, inflamed, it's being angry, it may not be able to convert ammonia to urea. And then their ammonia goes up and now they have an encephalopathy. So those are just all things we're looking at. Now let's talk about esophageal varices. And esophageal varices only come from one thing. They come from portal hypertension. Portal hypertension in the United States only comes from one thing, and that's cirrhosis of the liver. In the U.S., what's the number one reason for cirrhosis of the liver? Alcoholism, right? Now, remember that on the test, you're going to have different types of questions. You can have synergy questions, basic knowledge, and some questions that ask for some synthesis. You have to think about things before you can answer. In white people, in Caucasian people, to get cirrhosis of the liver, end-stage cirrhosis of the liver, it takes 20 to 25 years of daily drinking to have that happen. And you know what? There are some individuals that drink every day for 20, 30, 40 years and never develop cirrhosis of the liver. It's very individual how the liver responds to alcohol. But for us, for the consideration of this test, 25 years of daily drinking is going to end me up with chronic cirrhosis of the liver. And so this is what happens. The liver gets enlarged, it gets very lumpy, and it's not really painful, but when you touch that liver, you're going to feel it's going to descend over the costal angle. You're going to feel lumps. When you press on it, it might be a little tender, but not painful. So now you have this big liver that's full of blood. And as sclerosis, as fibrosis occurs, now this liver gets scar tissue, is going to start to shrink. And as it shrinks over time, this is taking over 25 years, it's going to get very hard, fibrotic. And what do you think is going to happen to the pressure inside that? Remember, anything that puts more fluid or anything that makes it more stiff is going to increase the pressure. So now, a normal liver, about 5 millimeters of mercury pressure. End-stage liver failure might be as high as 50 millimeters of mercury pressure. So it's a very high pressure system now. So the portal vein, which is bringing all the venous blood into the liver, now has to pump against that. But it's been over time, over 25 years, it's a little slow. So how the portal vein accommodates that is that it builds collateral vessels. But remember, they're veins. They're veins which have very little muscle, like an artery has much more muscle. So now this nice thin vein, thin-walled vein, is under high pressure. So it becomes ectatic, it becomes thickened, and aneurysmal. They start to look at these extra vessels that are being built. They start to look like somebody who has the worst varicosities you've ever seen, those big purple ropey things in the back of their legs. That's what they look like. And those accessory vessels that are built, the collaterals, are usually in the rectum, and those are hemorrhoids, or in the esophagus, which are esophageal varices. And remember, they're under great pressure. They're all venous. It's all venous blood. But instead of 5 millimeters of mercury, they could be under 50 millimeters of mercury. Now, where the synergy model might come in is that not all people metabolize alcohol the same way. The American Southwestern Indian, the Navajo, the Apache, the Hopi Indians, actually lack an enzyme in their liver to detoxify alcohol. So in that population, you could see a 14, 15, or 16-year-old come in with esophageal varices, rectal hemorrhoids, all the things we see in the 45, 50-year-old white person, you could see it in that Indian population. And they may have only been drinking alcohol for 2 years. So it's accelerated in that population. What do we know about Afro-Americans? What do we know about people from India? What do we know about Asian people? What do we know about Hispanics? We don't know if different populations of people, different ethnicities are different. We know a lot about Caucasians, and we know a lot about that special Indian population. Right? So 25 years or 2 years. I think that's very fascinating. All right, so that's the genesis. of esophageal varices. Now, one of those esophageal varices or one of those hemorrhoids rupture. Now, I have to tell you that if one of those external hemorrhoids rupture and this patient is gushing blood out, remember, what is our job? We have to stop the bleeding. That's why we have Kelly clamps. That's why you got one on your uniform all the time or your scrubs. That hemorrhoid that's sticking out, it has to be external. You're going to clamp it. Well, it'll only hurt for a second. It's going to burn like heck when you put that on, but you have stopped the bleeding until someone can come and sclerose that hemorrhoid. If it's an internal hemorrhoid, you're not going to stick the Kelly clamps up somebody's butt, but you may have to put a finger up there to try to stop the bleeding. All right? So we're going to stop the bleeding. We're always going to do the ABCs. If they're bleeding this way, we got to get that airway controlled. You know, breathing, circulation, IVs, Foley, volume resuscitation. But what we're hoping is that GI comes as soon as possible to ligate, sclerose, or band those esophageal varices or the hemorrhoids. Now, when they come and they stop the bleeding, we're very happy. Patient's not bleeding anymore. However, the banding or sclerosing doesn't really do anything for the portal hypertension. So it's just going to happen again, maybe from a different spot, but it's going to happen again. We might start vasopressin, we might start octreotide, right? And the surgeon or the interventional radiologist might say, sir, if you can promise me you will quit drinking, I can do a TIPS procedure which alleviates some of that portal hypertension. So they will stop the bleeding and then do a TIPS procedure. But remember, the person has to promise that they're going to quit drinking. And what do? They all say, oh, doctor, I promise I'm never going to drink again. So in the hospital, that's true. We're giving them the CWAB protocol. They're managing very well. They got great blood pressure. Things are looking great until they go home. They go home to the same environment. We didn't teach them any new coping mechanisms. We just gave them medications to get off the alcohol, and they start right back. The recidivism rate, the return rate to alcoholism is very close to 75%. Even people who have been, clean and sober for 10 years, 15 years, something happens and they go back to drinking. So it is a DSMO. It is a real diagnosis, righty? And it can be hereditary. So there's a lot to care about the patient with alcoholism, right? And then all the other complications, electrolyte bleeding, transfusions. What's the first clinical sign of alcohol withdrawal? Remember? It's not seizures, not trembling, it's tachycardia. Patient who is withdrawing from alcohol becomes hypermetabolic, they have a fever, and they get tachycardic. So just remember, if they ask you that on the test, seizures is not the answer, right? The answer is tachycardia or fever. Later on, around 3 days, maybe some shaking, and then the hallucinations begin. And the drug of choice for the patient going through withdrawal is a benzo. We can use Ativan, we can use Valium. All righty. Now, this is a great picture. This is, when you look at this, I'm going to look at my screen. So you look at your screen, look at that picture. That's looking down the esophagus. That's from the GI. And those big purpley things with the top little black band, those are esophageal varices that have been banded, righty? But don't they look horrible? And this is right at the esophageal gastric junction. And that's the most common place for esophageal varices. Now you can see there's a clot down there, and you can also see that there's red blood coming from above. There's another big varice that's bleeding from above. Now when I see a picture like that, I just wonder, what does this person eat? You can't eat a piece of toast or a sandwich. That would be painful and they'd start bleeding again. Remember, at end stage alcoholism, what are they eating? Not much. They're drinking alcohol. And so when they come in, their blood sugar usually is very elevated. Alcohol is a pure, simple carbohydrate. Your blood sugar is going to go up. But if we're not going to give them any more alcohol, what happens to that blood sugar? It drops very quickly. And most people have the misconception that their liver's dead. If you have a high blood sugar and it drops very quickly, we think, oh my God, there's something wrong with their liver. Well, there is something wrong. The liver's not dead. They just don't, we're not giving them enough sugar substrate, and they don't have any stores. Alrighty? So that's esophageal varices. Now, hepatic failure. When you think about a patient that has true hepatic failure, end-stage hepatic failure, you think of a patient who's very edematous, who is jaundice, who's sitting bolt upright, has a lot of ascites, is short of breath. When they scratch, they're bleeding, they're coagulopathic. When they even have tears, they're yellow. So they're short of breath, they're not making much urine, they are febrile, they're tachycardic. It's really, liver failure really takes a toll on everybody's system because the liver controls over 200 functions for the body. Protein, carbohydrate, and fat metabolism. All your coag factors are made by the liver, and when the liver is upset and it gets angry, the spleen also gets angry, and the spleen starts eating all your platelets. So your liver's not making any coag factors, right? None. And your spleen is eating all your platelets, so you have thrombocytopenia, and the patient is coagulopathic, and they bleed from everywhere, right? And then the neuro complications. Acutely, what can cause acute pancreatitis? Hepatitis. We always think about viruses like fulminant hepatitis, but CMV can, and herpes simplex. You know, when you look at the virus herpes, there are actually 16 different species under there. Herpes simplex, you know, fever blisters, herpes zoster, chickenpox, erythema multiforme, which is another word for Stevens-Johnson syndrome, that can be all initiated by the herpetic lesions or the herpes virus. And remember, when somebody gets herpes, it stays in your body, and then other things trigger it, like fevers or stress or being out in the sun. CMV as well. Hepatotoxic drugs, Tylenol. Now, they've usually taken overdoses off the exam. 10 or 12 years ago, there were always questions about that. Last time I took the exam, which was June of this past year, or this year, no questions. But if you get a question, you have to remember that aspirin and Tylenol are the two most common non-intended overdoses. And where I live in northern Florida, there's a lot of country folk, and for their arthritis, they take BC powders. So BC powders are aspirin, and they might take 10 or 12 BC powders in a day for their arthritic pain, and then they get a stomach ache, and then they take Alka-Seltzer, which also has aspirin. So that's why it's unintended. They're self-treating with products, over-the-counter products, that they don't know has aspirin in it. So they overdose. Aspirin is a terrible overdose. It causes a very significant metabolic acidosis with rhabdo. Tylenol overdose is going to kill the kidney. And remember, what's the antidote for Tylenol overdose? Mucomyst. You're right, mucomyst. Right? Give it as soon as possible. Of course, shock liver, we see that all the time. You take care of hypotensive patients 2 or 3 days, or even sometimes even sooner, 2 or 3 days after their profound hypotension, their shock event, their malperfused state, they then begin to develop liver failure. And then there's some other causes that aren't so common. And then chronic liver failure, remember, number one is cirrhosis. So the number one cause of cirrhosis is alcoholism. Number two is fatty liver of obesity. And number three is hepatitis. It used to be hepatitis number 2. Now we have a brand new drug for hepatitis. We're getting better control for hepatitis. But obesity is a big problem in the States. And now we're seeing fatty liver with end-stage liver disease from being obese. Righty. Wilson's disease is a very rare disease. I've never seen a case of that, and it can become of two ways. One is congenital, and a young person, a toddler, turns bronzy color. They go into complete liver failure because the liver cannot metabolize copper. And so these young babies are going to get a liver transplant as soon as possible. Righty. Older a patient develops or acquires Wilson's disease is they're working in a place where there's a lot of copper mine, a coal mine, where copper is in a dust form, and they either inhale it or absorb it through their skin. So it's really an occupational hazard for those miners. And then, of course, tumors of the liver. So remember, we're going to have liver failure. The liver's not working. You're going to have portal hypertension and the things that we see. We already talked about esophageal varices. We talked about the splenomegaly. Remember that the spleen sequesters and stores vitamin K. So now no coags, no platelets, no vitamin K. So that's why we often have to give these people a milligram of vitamin K, sometimes a half a milligram, 5 milligrams every single day, IV, not IM, the patient is coagulopathic, daily for replenishment of that vitamin K. Carbohydrate, fat, and protein metabolism is all altered. These patients, in the old days, we never gave them protein. We restricted their protein because protein breaks down to amino acids, nitrogen, and ammonia. Their BUN is going to go up, blood urea, nitrogen, and their blood ammonia is going to go up because the liver can't fix that. And so we stopped giving them protein. But the reason that they have so much ascites is that their albumin, their prealbumin, are very low. These are people that haven't been eating very well and their protein levels are low. So oncotic pressure, remember we talked about that, oncotic pressure at the capillary bed drops down, there's not enough protein. So now the big holes appear in the capillary bed, and that's why these people have so much ascites. So when you look at this patient in liver failure, they look very edematous, they look very volume overloaded, they're short of breath, and you want to diurese them. Problem is intravascular volume is actually depleted. So what they really need is good volume, just that will stay in their vessels, and they need protein. So in these patients, we may have to give them protein. We might be putting Dobhoffs in and giving them jet fuel protein and then giving them lactulose, 30 mLs every 6 hours to get rid of the ammonia. There are several new drugs out on the market for dropping ammonia levels, but they're not on the chest, just lactulose. Just lactulose. All right? Now, and that's this slide right here. Ammonia converts to urea by the liver, the normal liver. Not you get encephalopathic, a metabolic encephalopathy. So now when your patient has fulminant hepatic failure, you can see on the slide there what condition you're going to see: tachycardia, maybe hypotension, bleeding everywhere. But there's a very interesting question on the exam, and it says, why does this patient have respiratory alkalosis? Respiratory alkalosis. You and I know that respiratory alkalosis is caused by increased respiratory rate or hyperventilation. All right, the patient's hyperventilating. But why are they breathing fast? And you say pain, temperature, anxiety. Stop saying those things. Why does somebody breathe fast? Because they have tissue hypoxia and or metabolic acidosis. This patient may have some metabolic acidosis if they're really hypotensive, but what they have is tissue hypoxia. And here's the reason. The liver, remember the diaphragm, if this is the front of my chest and that's the back of my chest, so the diaphragm curves. It's higher in the front and it curves down in the back. There's a sulcus in the back. So the diaphragm looks like this, right? The liver fits right underneath the diaphragm. When the liver is angry, when it's inflamed, it makes a fluid. And that fluid is so toxic that it gets out of the capsule. It eats its way right through the capsule. The liver is encapsulated. And now that very toxic fluid is sitting right underneath the diaphragm. Well, it's so toxic, it makes holes in the diaphragm. And that fluid, that very toxic fluid, not translocates. It moves across the diaphragm. All right, not exudate, but transudate. There's the word. I had a little stroke there for just a second. It moves from here across the diaphragm into the pleural space. Now, you know the pleural space is very low, right? And now you're putting a lot of fluid in that pleural space. The pleural space is getting bigger and bigger and bigger. And what happens to the lung? It gets compressed, right? So if your lung is compressed, you don't have enough volume in that lung, so the FRC, functional residual capacity, goes down, and they become hypoxic because like they have half of their lung working, and they're breathing faster, 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 faster. All right, and the long explanation for why they breathe fast, that's a very good one. Now remember on the exam, this is going to produce a right pleural effusion. The patient is terribly short of breath. They can't get out of bed without being terribly short of breath, and you're worried. You're giving more and more oxygen because they're desatting. When you listen over a pleural effusion, what do you hear? And so many people want to say they hear rouse. No. Rouse means that there's fluid in the alveolar space. There's no alveolar space there. Remember, the lung is all compressed. So I'm going to skip to the next slide just to show you this. See that right pleural effusion on that x-ray? That lung is totally compressed. Right above the really white, when you're looking at that, there's very hazy. That's where the lung is compressed without atelectasis. So when you listen over a pleural effusion, you hear no breath sounds, absent breath sounds. Don't write diminished. Don't write rouse. You hear nothing over that. Righty? Now, they have so much fluid in there, they're having trouble. So the doctor wants that taken out. They want either a pleural thoracentesis or they want a chest tube put in. And most likely they're going to get a chest tube because they keep making that fluid. But their INR is 5. You cannot send that patient to IR. They are not going to touch your patient unless the INR is less than 2. So you can give them some FFP, you can give them vitamin K, but remember, they are appearing fluid overloaded. The more FFP, the bigger that effusion is going to get. So somebody has to come and put a tube in, thoracic surgery is called, they come in and put a tube under ultrasound. They're going to put a small, like a 12 French pigtail, in there and let it drain. Patient's going to feel much better, they're going to cough, but they're going to get better, their stats will improve. But when is that chest tube going to come out? Less than 100 cc's in a 24-hour period, and that may be weeks until the liver is improved, right? Or maybe never. So they're going to have to go home with that. That's why we want to put a small tube in. It's a long explanation for respiratory alkalosis. So how are we going to treat this person? Well, we're going to avoid hepatotoxic drugs, and I hate to tell you what's hepatotoxic, besides Tylenol. Sedatives, narcotics, and tranquilizers. And what are we giving them for their alcohol withdrawal? We're giving them Ativan, Valium, you may be giving them pain medications, and so they may last a little longer. You never know with this alcoholic, if you give them 1 milligram of Versed, how long it's going to last. 1 milligram of Ativan. So you have to be careful in watching the patient's neurostatus. Alrighty. Avoid alcohol. I wish we could give all of our patients alcohol in the hospital, but we can't. Monitor their liver functions, monitor all their labs, make sure we're supporting every system, the kidney, the lung, the heart, the liver. Watch their electrolytes. In this patient, they're going to have a low potassium, even when they're going into renal insufficiency, low potassium and a low calcium. If the calcium's low, and that's another reason why they have a bad heart, their heart's not working well, and why they're hypotensive. So we may have to be giving them a lot of calcium. If the calcium's low, what's the phosphorus? It's always elevated. They're always in reverse, right? Low calcium, high phosphorus, right? So look at all the complications that we see from liver failure. It's multi-system, including cerebral edema, acute necrosis, kidney injury and kidney failure, ARDS, sepsis. The list is never ending. These people are very sick. That's why they're in the ICU. All right, now here's your favorite thing, and that's pancreatitis. The ER calls you and says, I got a patient with pancreatitis, and you say, I do not have any beds. And they say, I'm looking at the computer and I can see you have a bed. And you say, oh, that's a stroke bed, a STEMI bed. You're trying to save that bed because you don't want that patient with pancreatitis. And guess what's going to happen? You have to take the patient. Now, when you start reading about pancreatitis, you know that this is something has caused a huge inflammatory response to your pancreas. It's very angry, and it begins producing a lot of proteolytic enzymes that are being released inside the pancreas itself, not into the duodenum, into the pancreas, and that's what we used to call autodigestion, is eating itself. So the pancreas gets very swollen, very edematous, and it is exceedingly painful. If some of those proteolytic enzymes eat through a tiny blood vessel, now you have from interstitial pancreatitis to hemorrhagic. And that's why we're watching their H&H so closely. But in today's world, 2015, the way we talk about pancreatitis is acute pancreatitis versus severe acute pancreatitis. Let's talk about acute pancreatitis. It's usually an alcoholic. They come into the ER with very diffuse pain, righty? And that's their major complaint, diffuse pain. They're tachycardic, maybe a little hypertensive, they may have a fever, may have a white count, but they are hemodynamically stable. You give them some pain medication, you have to admit them, and they have to go to telemetry so you can monitor their heart and their heart rates and their rhythms. But after five days or so, their enzymes, their amylase and lipase, come down. The patient's afebrile, they're out of pain, they go home. Mortality rate in this person is less than 1%. It's very low. And they do well, they go home. But if they continue to drink, you know that they're going to come back. You know they're going to come back. So acute pancreatitis, we probably won't even see in the ICU unless they have a heart attack with it or unless there's something that makes it more complicated. As opposed to severe acute pancreatitis, SAP, SAP. This is Dr. Smith, who is a Southern Baptist minister. He preaches every Sunday, has a great congregation, and he has never in his life had one sip of alcohol. And he comes into the ER at about 10 o'clock at night complaining of 10/10, the worst substernal chest pain he's ever had. I feel like an elephant sitting on my chest. He's 65 years old. You're going to go through the chest pain protocol. His EKG is sinus tachycardia, but no signs of ischemia. Troponin is negative, but he is in pain. He's got a little bit of a white count, a little bit of a fever. He's sweating. You're giving morphine. You probably gave him some aspirin. All the things that we would do for a heart attack, but he's not having a heart attack. So the ER doctor is going to say, well, let's send him down for chest CT. Maybe he has aortic aneurysm or aortic dissection. So we send him down to CT scan. By the time he comes back, the CT scan is going to be normal. The rest of the labs are back. His LFTs are off the chart, and his amylase and lipase are in the thousands. This man has severe acute pancreatitis. And while he's waiting to be admitted, his blood pressure is going to start going down. He came in a little hypertensive with all the medicine, with all the pain, and now everybody says, well, it's because we gave him so much pain medicine. That's not true. His blood pressure is dropping because what's happening is he's becoming entirely inflamed. It's not just the pancreas. His whole body is going to be inflamed, and histamine is going to be released, and what's going to happen to all his blood vessels? They're going to dilate, and his blood pressure, systolic and diastolic, is going to drop like a rock. He's going to be very tachycardic. So our go-to treatment of hypotension is to give him fluid. So he gets 3 liters of fluid, and his blood pressure is not responding. So you're given the 4th liter, and you start some norepinephrine, right? Handy little drug, norepinephrine, Levophed. So we've got him on that. Blood pressure's still not going up. So we're making that Levophed higher, and then we're going to start vasopressin. We've given 5 liters of fluid. He's on 2 vasoactives, and doesn't he sound just like a septic patient? Yeah, but he's not infected. You can do blood cultures, you can do a urine culture, you can do spit in a cup. He's not infected. This is all from severe acute pancreatitis and this huge systemic inflammatory response. So just as they're getting a bed upstairs in the ICU, what happens are his SATs start to drop. And everybody says, oh, Cammy gave too much fluid. That's not the case. You can't give these people too much fluid. The reason is he's so inflamed, he's going into very early ARDS. So he gets intubated. By the time we get him in the ICU, he's intubated on 100% FiO2 and 5 of PEEP. They can't go up on the PEEP because he's still hypotensive. He's 10 liters positive, and he's on vaso and levo, and you're thinking about starting epinephrine because you can't get a mean arterial pressure above 55. He's not making any urine. He's not awake and alert from his sedation. His lungs sound terrible. His belly's distended. He is a mess. Mortality rate in this patient is 25%. And as a matter of fact, when you do his glucose, it's going to be 600, and he is not a diabetic. His K is 2.5 and his glucose is 600. He's not acidotic. What does he have? He has hyperglycemic crisis. Remember, pancreatitis can give you either DKA or hyperglycemic crisis. So he is very sick with a 25% mortality rate. If I were the charge nurse, I would give that patient the best, smartest nurse I have because it's going to take a lot of maneuvering to get him better. And of all the treatments we have for this patient, all the supportive treatments, the number one thing for nursing to do is control his blood sugar, which might be very difficult. His pancreas is so angry it doesn't know what it's doing. So very tight blood sugar control will lead to a better outcome, a positive outcome. Righty. So some of the things that can cause it, well, yeah, 50% of all patients that we see in the hospital with pancreatitis is due to alcoholism. But that's just 50%. What about the lady that comes in that's fat, female, and 40 and complaining of belly pain? Gallbladder, either sludge or stones. And because you have this inflamed and obstructed gallbladder or common bile duct, you can develop pancreatitis. So you, the nurse, are going to be admitted to the floor in which you work with pancreatitis. And everybody behind your back is going to say, well, I didn't know she was a drinker. Oh, I didn't know she was a drinker. Boy, she hid that all. I've known her for 10 years. I didn't know she was a drinker. It has nothing to do with alcohol. It's that inflammation of the common bile duct. And nobody wants to have a cholecystectomy anymore. Nobody wants a big surgery. They want a belly button surgery. So ERCP, where they go in endoscopically and remove the stones or the sludge, is going to even make the common bile duct more unhappy, and that's a really common cause of pancreatitis. And look at the bottom there, 20% is idiopathic, which means we never find out why they have it, and no matter what causes the pancreatitis, no matter, you can get it again. You can get it more than once. It becomes recurrent pancreatitis. I've already talked about the physiology. Now, the patient may look acutely ill. They may be hyperthermic. They may look like they're having an MI. They may be nauseated and vomiting. In just plain acute pancreatitis, the pain is sort of diffuse. In severe acute pancreatitis, it's sort of in the right upper quadrant to the midline. And it's very painful, very painful. Right? Do you remember what Gray Turner's sign is? Ecchymosis on the flanks. Yeah, so that they've got bruising on the flanks. And then they could come in shock. So clinically, their calcium is low, their potassium is low, and they're hyperglycemic. That is the key on the test. You have to know that this is hyperglycemic crisis. They're not acidotic. Their K is low, but their sugar is high. So we're going to fix that. Their serum amylase and lipase are elevated, and their urine amylase. Now, I have never ordered a urine amylase. I've never sent one. I've never had anybody ask me to do one, but it is clearly in the book, and some GI doctors do order that. So remember that the answer on the test might be serum and urine amylase. Liver, your LFTs, might need a CT scan and an MRI. So how are we going to treat this patient? Well, for years it was NPO, NG tube. Don't give the patient anything to eat and just wait till they get better. And now we know that feeding the patient is mandatory. We got to feed the patient. But since it's so new and since the guidelines have changed so much in the last 3 years, you're not going to see a question on it. Right? Remember that everything has to be pretty standardized to be on this test. So the question they may ask you is, this patient's in terrible pain, how are you going to treat their pain? Well, in the old days, we didn't want to give morphine because it may have caused the sphincter of Oddi to spasm. I'm not sure if that's really true, because I think you can still treat with morphine, but I know for sure you can't use Demerol because Demerol is not on your formulary anymore. But you have other drugs. You have Dilaudid and fentanyl, which are such better drugs. Fentanyl I love because it's fast acting, and if you give a little too much, it wears off fast. Righty? PCAs would be perfect for this patient. Righty? Then we have to do all the other things like alcohol withdrawal, complications. Remember, 25% of these people are going to die. And if they get an abscess in their pancreas, now they also develop sepsis and need antibiotics for at least 7 to 10 days. Okay. Now, intestinal infarction. Ooh, this is an ugly, ugly, ugly thing. If somebody infarcts their whole intestine, small bowel, large bowel, they are going to go to heaven. You know, no matter what we do. And a lot of times this elderly patient comes in the ED that, you know, has been telling their family they haven't felt good for several days. They haven't had a normal bowel movement in a week. They just feel terrible. Now they start vomiting and the family brings them in and they really do already look like they have an acute belly. And what has happened is their whole gut has died. And what the family, maybe they're 85 years old, and the surgeon comes in and says, oh my, this is bad. We do a CT scan, there's ptosis, in all of the bowel, and the doctor says, this is very bad. I can't do anything for you. And what does the family say? Oh, please do something. We want everything possible done. And the poor man's 88 years old and a lot of pain. He should have palliative care and treat his pain. But they're going to take him to the operating room, and if it's a really happy surgeon, he's going to do a whole X-lap, look in there, and the whole bowel is dead. And then he's going to put big retention sutures in and send him to you because he can't die in the OR, and he's not going to die right away, and we're going to do comfort care. So we did a big procedure on somebody that is going to have a very poor outcome. Very poor outcome. If part of the bowel is dead and the patient gets a hemicolectomy, part of their colon, they have an ileostomy or colostomy, you know that this patient's going to be very sick when they come out of the OR. Okay. Some of the causes of intestinal infarction are anybody on vasopressors, vasopressin, Levophed, neosynephrine, high-dose dopamine. They can get ischemic bowel, and that ischemia goes right into necrosis. Anybody that's had their aorta clamped, like for AAA or descending aorta surgery, because now their mesenteric vessels are not being perfused. But let's talk about atrial fibrillation. In atrial fib, remember, the clots are always arterial that come out of the heart. Now, I want you to think about that. The right and left atrium are fibrillating, right and left. But the right atrium is very smooth-walled on the inside and very rarely makes a clot. It's very rare. Just think about that. If all your patients in atrial fib had clots, they'd all be full of pulmonary emboli, and they're not. It's the left atrium. The left atrium has that little appendage on the side. Blood swirls around in there, and when the atrium has finally a synchronized clot, a piece of contraction, a piece of that clot comes left atrium, left ventricle, out the aorta, and usually to the head. You have carotid, goes right up the carotids, and they have a stroke. All right? 1/3 of all strokes come from atrial fibrillation. Well, what if they have carotid stenosis? What if you can't really, that clot can't go north? It's going to go around that arch, down the descending, and it's going to go right to the celiac artery. That's the next big artery that comes out. So from the celiac, it could cause the spleen to be infarcted, or it goes to the superior mesenteric artery. That's the artery that feeds the whole bowel. Superior and inferior mesenteric artery feeds the whole bowel. So if that is occluded with a clot, they're going to have bowel ischemia and then bowel infarction. Okay. So what does the patient look like? Well, they don't look so good. They could be anorexic, they could be vomiting, they could be pale, they're going to be hypotensive. Now, that doesn't happen right away. They might stutter a little bit and then feel really bad. They might say, nurse, hurry, I need a bedpan. Whoa, too late. And it's a big bloody bowel movement. Now, those of you who take care of AAAs a lot, the old-fashioned AAA where they actually open the belly, clamp the aorta, and fix that aneurysm, or maybe it's ruptured and that they urgently went in. About between 0 and 4 hours out of coming out of the OR, you're across the room and you say, oh God, he's got a GI bleed. They have that distinctive smell. You go over and look under the covers, and it looks like a little jellyfish. It's just mucus. There's no stool, no blood, no anything. It smells terrible, and that's where the bowel, your mucosa of the bowel, has shed from ischemia, from bowel ischemia, righty? So they can have that, righty? But usually they're tachycardic, hypotensive, and they don't feel good. They don't feel good. Our job, ABCs, is put the head of the bed up. You're going to vomit. Stop all feedings, no tube feedings, no anything. Put the head of the bed up. If you can get an NG tube, decompress the stomach. Sometimes you can't do it. If they're bleeding again now, you may not be able to do that. But NG tube, you have to stop all the vasopressors, and the only way you can treat their hypotension is with volume. More and more and more volume. But when the bowel, remember the bowel is all muscle. This is all muscle, a lot of vascularity in that muscle. As I'm pumping in the fluid, because this is so ischemic, the capillary beds are not normal, and that fluid that you're giving gets inside the bowel wall, makes the bowel wall very edematous. So you start seeing, from a nice flat stomach, to start seeing some distension of the abdomen. So what can that lead to is intra-abdominal compartment syndrome or increased intra-abdominal pressure. Most likely the way you are measuring intra-abdominal pressure is with a Foley. Dr. Wolf's handy-dandy measuring kit for the Foley. It works great. Remember too that your abdomen really doesn't have any pressure in it. It doesn't. If you had pressure in your belly, your aorta would be compressed and you wouldn't get any blood flow to anything. So when you get an intra-abdominal pressure of 18 millimeters of mercury, we say that's abdominal hypertension. If it goes to 25, now this is an abdominal emergency because nothing you've seen, the kidneys are not working, nothing in the gut is working, and you have to open that belly and release that pressure. Open belly at the bedside. So what are you going to see? It's a good question. What are you going to see in the patient that has abdominal compartment syndrome? What are the signs you're going to see? Tachycardia, very good. You're going to see tachycardic. They're going to get a narrow pulse pressure, but maybe they already have that. What you're going to see is increased respiratory rate. The alarm on the vent keeps going off, the pressure alarm, because when the belly gets distended, the diaphragm comes up, and now what happens to both lungs? They're compressed, so your FRC is lower, and your pressure in your lung goes up. So that's why your peak pressures are going up. There's no fluid in the line. You suction, there's nothing there. It's because it's from their belly. The second thing you're going to see is on the vent. Remember, peak pressures, increased respiratory rate. The second thing you're going to see is decreased urine output. The kidneys aren't seeing enough perfusion. So this is bad. Abdominal hypertension. Now, GI infections is another new part on the exam, and a lot of patients in the ICU get diarrhea. Now, here's a Cammyism. This is totally what I think. I think diarrhea in the ICU is really secondary to tube feeding. But if you tell anybody that's in charge of writing orders for your patient, your nurse practitioner, your PA, the physician, the resident, the intern, as soon as you say diarrhea, they say C. diff. Right? We're paranoid about C. diff. So you're going to send a C. diff, it's negative. Why do they have diarrhea? Probably because of the tube feed. Now your nutritionist says that's not true, but if I'm giving hyperosmolar fluid into the bowel, it's going to pull in a lot of fluid and then they get diarrhea. Right? So diarrhea can be viral, parasitic, bacterial, consequence of critical illness. So C. difficile is a consequence of pseudomembranous colitis in the bowel secondary to antibiotic therapy. Now in black on this slide is the actual definition, and you're going to argue with it, and I argue with it too because we don't often see this. It's greater than 3 days of watery, foul-smelling stools and a history of antibiotics. This is what we miss sometimes. The patient may have had antibiotics 4 months ago, and we don't even know it. The patient doesn't know it. The patient doesn't even remember they were on antibiotics, so we may have no recent history of that antibiotic use. Alrighty? And then the last part is that they have colitis, so they should have belly pain. When you press on their colon, they should have pain. That's what I argue with. I have patients with C. difficile, and they have no pain. There's no pain in their abdomen. So that's an iffy thing, the abdominal pain. But watery diarrhea with a history of antibiotic use. So you're going to send your PCR, most common. We don't do ova and parasites anymore, and we don't do stools for culture and sensitivity. That takes too long to get back. We want that PCR, which is very good. Make the diagnosis. We shouldn't be treating empirically. We should wait till we get the diagnosis unless the patient is becoming, instead of just C. difficile infection, they have sepsis secondary to C. difficile, and they're hypotensive, tachycardic, and we're resuscitating. Right? So the drug of choice for today, the first line drug of choice is Flagyl, and it can be PO or IV. It doesn't matter. It does not have to be PO. If their gut's not working and they're vomiting and having diarrhea, we can give it IV. Then oral vancomycin, and if you're going to give either one, 10 to 14 days. Alrighty? So remember, you have C. difficile infection. Patient's going to have diarrhea. They're going to have a little belly pain, a little white count, a little fever. Give them antibiotics, they get better. Severe C. diff infection is going to look more like sepsis. It's giving the patient hypotension. They need those antibiotics. They need volume resuscitation. Sepsis, volume. Okay, good, good. So you need proper antibiotic use and proper isolation. If the patient in A has C. diff, B should not catch it from them. So a good question is, how long does C. difficile last on the table? You just might as well say forever. It lasts for a long time. And now I just read an article just this week that UV lighting used in the ICU kills C. diff. Maybe we'll walk around with one of those lights and kill all the C. diff, or maybe somehow we'll put UV lighting in the ICU to kill bacteria. I think that's a great idea. I like the Sidex little wipes that we have, but remember, please to put your gloves on when you use that. All righty. So remember the gut nutritional support and remember electrolytes. You have to remember electrolytes. Okay? What do you need to remember? Everything. The arterial perfusion of the small bowel is, and the large bowel, the whole entire bowel and the intestine, is the mesenteric artery, superior and inferior. Comes right off of the celiac. Complications of pancreatitis. Now remember I said that when the liver is angry it makes fluid? Well, so does the pancreas. And it usually gives the patient a left pleural effusion. So remember, what do you hear over a left pleural effusion? Absent breath sounds. If you listened to the patient and you heard bilateral rouse, you would think the patient's volume overloaded. Correct? Yes. If you heard rouse just in one space, I just hear it right here, right middle lobe, that might be atelectasis or pneumonia. Right? So listen very carefully and be careful what you write down for breath sounds. The patient with pancreatitis may get into ARDS. They may go into hyperglycemic crisis, and they have low calcium, so their phosphorus is high. Cullen's sign is ecchymosis around the umbilicus. We're giving you information about a retroperitoneal bleed. Kerr's sign is referred pain from the abdomen to the left shoulder. So they may have pain in the left shoulder or behind their scapula. It's caused by free air, blood, or fluid in the abdomen. But sometimes patients have a fractured spleen, a little bit of blood in their belly, and they get pain up here. That's Kerr's sign, referred pain from the abdomen. Right. So some questions. Now this is a very old question. I didn't have it on my last exam, but I've had it many times on the examination. It's goofy, but you may see it. The administration of vasopressin should be most carefully monitored in patients who have diabetes, CAD, hypotension, secondary GI bleed, and diabetes. Well, you can use vasopressin for a GI bleed, of course, but the answer is coronary artery disease. And the reason is vasopressin is a vasoconstrictor, but it can also cause vasospasm. So if you have underlying coronary artery disease, you wouldn't want those vessels who already have a flow limiting lesion to spasm. I know it's not a great question, but there it is. You're going to monitor everybody on vasopressin, but the patient you're going to monitor most carefully is coronary artery disease. The inability of the liver to conjugate what substance is a primary contributor to hepatic coma? Ammonia. Now, I have ADD pretty bad. And so when I take a test, I have to be very careful because I saw that word conjugate and my eye went right to bilirubin. Those two words go together. I don't even read the question. Good, go to the next question. You can't do that. You have to be so careful because this question has nothing to do with conjugate. It has to do with ammonia. So what I do when I take the test, I know this sounds goofy, is I read the answers first, then I read the question, then I pick the answer. It makes me make sure that I read all of the answers carefully. All right. Cimetidine or ranitidine acts to reduce stress ulcers by inhibiting the production of which substance? Answer is histamine. Remember, they're H2 blockers. H2 blockers. Which of the following laboratory findings is most specific for pancreatitis? Now let's just look at leukocytosis. Leukocytosis is very sensitive. Very sensitive. As a matter of fact, your patient could be FOS, full of stool, just being impacted, and that alone makes their white count go up. So it's very sensitive, but not very specific. You don't know where the problem is. So no, leukocytosis wouldn't be the answer. Elevated serum and urine amylase. Please don't forget that urine amylase can be an okay answer on the test. All right. So we've done GI. Remember that GI bleeding, you might have questions about blood in here. What blood product do you want to give? After 4 units of blood, you have to follow up with the coags. What coags do you want, doctor? I want all of them. PT, PTT, fibrinogen, platelets, and maybe an H&H. So these types of questions, they're going to ask you with the follow-up. What do you anticipate the doctor ordering? What do you think is going to happen next? All right, that's the end of GI. Thank you very much, and I'll see you for the next module.